I believe that we we've been on mute and we've started the meeting. So I'm just gonna do that again. So thank you all for joining us online. I'm just gonna briefly go through some housekeeping before I hand over to Ian. So hoping that everyone can hear me, and if you can't, just let us know in the chat function, which you'll be able to interact with us online. We're using a different format today, so we don't have our cameraman, but we will be using a PowerPoint presentation that Ian will go through. I will be monitoring the chat. That's Tanusha Ramalou, the GPLO. I would like to begin by acknowledging the traditional owners of the land on which we all meet today, paying my respects to elders past, present, and emerging throughout the many countries that the Darling Downs and West Moreton region represents. On behalf of everyone present here today, we acknowledge the need to continue working towards reconciliation and the continuation of cultural, spiritual, and educational practices of Aboriginal and Torres Strait Islander peoples. This webinar is part of a series that we've run with Ian, focusing on behavioral and developmental issues for children and young people. All these webinars will be housed and can be watched in, by colleagues who might not have been able to make the live webinar series on the PHN website under online education for primary support, and also on the Ipswich Hospital Foundation website. Today, our webinar will be focused specifically on medication management, which is something that we put at the end, Ian, because we really want to avoid using it. However, it does become necessary and actually can work quite well. So Ian will focus on the overview of the medications that can be used, but then specifically on the classes of these medications, and then specific medications, you'll drill down further into the specific medications. And I think from a general practice, probably parent perspective, is really that side effects, monitoring of efficacy, and all of those aspects, which we can actually probably do well in primary care and then refer on if we're having trouble to the specialist. So I will hand over to Ian. I'm hoping everyone can hear us loud and clearly.
Well, thank you, Tanusha. Welcome, everybody. I hope you've enjoyed the past webinars, which are still up and available, as Tanusha mentioned. So we went through taking a history in children with behavioral developmental disorders. We spoke about basic behavior modification. We spoke about further investigations and the way we might use therapists to achieve those assessments. And then we spoke about the diagnostic difficulties within this whole area. And today we're going to drill down onto psychotropic drugs in pediatrics, which has been an area that still contains quite a deal of controversy. So firstly, what about the choice of resorting to a medication? After all, the medications we're going to use are not curative. They are palliative. They can have significant side effects. So we'd be wanting to think about, have we maximized all the non-medication approaches? So the maximization would be thinking about, at home, have we put in the kind of supports that might help parents to manage best? Have school put in the appropriate supports to look at managing children? And we've spoken before about the combination of behavioral modification, of sensory supports, of the taking breaks, of creating order, and the sort of things that help children cope, including movement breaks, giving children space to think, and so on. So these should have been maximized. The only variation on that might be a child who's at risk of suicidality, where we'd be really wanting an urgent referral. And in that situation, that would generally go to child psychiatry, not pediatrics. So we'd be expecting you to contact and make referral to child and adolescent mental health services. So just as a background, there's been an enormous increase in the use of psychotropics in pediatrics. Since roughly 1990, there's been a more than 5-fold increase in the use of medication. And I think we don't know yet in the long term what will this mean. There are very few long-term studies of the effect of using these medications for prolonged periods in childhood, with the possible exception of some of the stimulant medications. Pediatricians are actually responsible for initiating the majority of these prescriptions. GPs do a significant number of prescriptions, but these are generally continuing on things that pediatricians have been prescribed. The class of drug where this is not true would be things to help children sleep, where we find both parents initiating prescriptions through non-prescription services, GPs providing prescriptions, but of course also pediatricians. Child psychiatrists probably initiate a minority of prescriptions for children with neurodevelopmental difficulties, perhaps in the order of 10% or so. The majority of prescriptions made other than sleep are for attention deficit hyperactivity disorder or attention deficit disorder, which roughly accounts for 2/3 of prescriptions in children, followed by antidepressants, currently around 1/5, but it's one of the areas that's increasing in prescription rate, and then antipsychotic medications, probably accounting for about 10%. Of the medications, methylphenidate is the most commonly prescribed, then risperidone, fluoxetine, dexamphetamine, atomoxetine, and then sertraline. One has to remember when you are prescribing psychotropic drugs in children and adolescents, they're more vulnerable to side effects than adults, mainly because they have an increased amount of dopamine in the areas of function that we're aiming at, particularly in the forebrain, and therefore changes in medication can have more dramatic effects than they might do in adults. We'd like you to be aware of and think of prescribing for children who are entrapped in families where there might be illegal drug use. So this can be a significant problem. The medications in that area may be misused by the people within those environments. They might be misused in the way they're given to children, either erratically or not at all, or they might be misused in giving children more than the prescribed doses. Children within those households may also be given other medications that have not been prescribed or have been prescribed by other doctors who the families have approached. So just be very wary in some circumstances of whether families may already have a problem with the way they use medications. In that situation, there are alternatives. For example, the medications prescribed may be able to be utilized only at school, though in that situation, we're putting the hard word on teachers who already have difficulties in managing children. We also risk labeling children, because if children are taken out of class or out of playtime to receive medications, then other children are generally aware, and this can be a difficulty for the child involved. As for the use of pretty well any medication you prescribe, we need to have adequate assessments to confirm the need to use psychotropic medications. In most common area of prescription, in attentional deficit hyperactivity disorder, the commonest screening tool would be the SNAP-4. It can also be used more definitively, but we'd really like the SNAP-4 to be used across a range of environments to confirm that it is abnormal in all environments in which the child functions, or at least both home and school, before considering using it as a support for the decision to medicate. A better tool is the Connor, which everyone's aware of, but it's also expensive. And many hospitals and general practices would find that a difficult imposition to withstand the cost of that tool. You can use a more generalized screening tool like the Strength and Difficulties Questionnaire, which is available free online, that will give you an indication as to whether attention deficit is perhaps not the only problem. It might indicate that there are also problems in other areas, which might then lead to using other tools. You can do things like behavior checklists. These are generally cost more, but there are also screening tools like the PEDS, which can provide useful information about whether a child may or not need additional things beyond the methods of managing home, using behavior, sensory, and so on that we've already mentioned. When you do decide that the assessments, both from school reports, from the assessment tools, from home, from your own observations, warrant going beyond the non-medication approach, then you must have a very clear idea, why exactly am I prescribing this? What am I hoping to do? Am I hoping that the child's learning will improve? Am I hoping that the teacher won't find the classroom regularly disrupted? Am I hoping that the family will be able to interact and play better with their children if they're able to modify those behavioral targets? So you need to have in your mind, what am I trying to change? Am I trying to change learning, the child's behavior, the child's sleep, or what is it exactly that I'm aiming at? After all, improving anyone's sleep will improve their daytime function.
And Ian, the other thing, I mean, we did bring it up in our previous talk, was around how important it is for the parent to have, like, you know, triple P or something like that is almost a standard, isn't it?
Absolutely. Yeah. And this is one of the non-medication approaches that should be utilized before you consider medication. Don't forget, there's not just triple P, which is available free online. There's also things like 123 Magic, Circle of Security, which are excellent programs, and there are a number of other programs also readily available. These can sometimes be accessed through things like Child Health or the knowledge of them, or they can be accessed through the non-government agencies. So there's a number of resources where you can go to before you begin this process of deciding to use a medication. Once having decided to use a medication, your next question before you take out your prescription pad, and this applies to pediatricians, of course, as well, is exactly how am I going to monitor the success or failure of this medication? In terms of success, what kind of monitors will we want school to utilize? What kind of monitors will we want home to monitor? So if our target has been improved learning, then we need to know, is this occurring or is it not? So has learning changed? And that's going to be a long-term monitor. There are some simple tools that can be used, like the SCAMP, which is a simple 5-test question that a teacher might be able to fill out, say, once a week, where it's not asking too much of the school to help give us feedback about how successful is this medication. If parents are cooperative, they can also use SCAMP, which is available free online, SCAMP, as a very simple tool that you might be able to utilize in order to help families function. So there's a very important tool requirement, therefore, that when you are going to prescribe, that you're very clear about what symptoms you're trying to improve, and secondly, how you're going to monitor and assess that. Okay. I have to now make sure that you are very clear that the use of psychotropic drugs in children under 8 years of age is grossly under-researched. It's probably best researched in the order of ADHD and ADD, but even there are significant limitations in the research that's been done. For example, some of the largest trials suggesting that it's of benefit have had a very limited number of behavioral interventions that they used as controls. We then have the additional difficulty that the investigation of non-medication approaches to childhood behavior and things is also limited. So we have a great deficit in the availability of reliable information about how effective the medications we're going to discuss are. And this is particularly true when we come into the antipsychotic medications and the anxiolytic medications, where information has largely been derived from adult studies, though there are some small studies in childhood that have been helpful. For example, the lack of clinical pediatric trials has been highlighted by both the FDA in the US and the European Medicines Agency as an area of acute clinical need. Because of this problem, many of the medications that we use in this area are prescribed off-label. When you prescribe off-label, the practice poses unknown and potentially serious long and short-term consequences for children, particularly long-term. I think most of us have got more comfortable about some of the short-term effects of medication because we've simply been using them, even though we don't have the evidence that we might necessarily want to see. Monitoring may require more than just schools and home. Pediatricians may require GP practices to put in monitors. We may have home visitation from non-government agencies who can assist with monitoring. We might have Family Connect or family services involved with a family where they may be able to assist us with monitoring. And sometimes we need to bring in all these tools, or maybe have workers from non-government agencies or Family Connect come in with families to inform us about how this has been progressing within the family. Because not all families are able to express themselves well when we're looking at both the positive effects and the potential for side effects with the medications. For some families where the follow-up visitors are unreliable, these services may be particularly valuable. There's a tendency within the area of prescribing psychotropics in pediatrics to say after a few weeks, particularly families, this medication is not effective, when medications have not been given a reasonable trial.
Yeah.
So that for any medication, if you decide it's not succeeded, then you must be aware that each successive medication you try has an even lower chance of success than maximizing the use of that first medication you prescribe, whether it's a sleep medication or whether it's some other form. So when you're maximizing the use of medication, a whole lot of questions come in, like compliance, the timing of the medication, the way you've introduced the dosing of the medication, and the time, the half-life of a medication, and the time that it takes to be effective. For example, we know that when you prescribe dexamphetamine or methylphenidate, we can see effects within a quarter of an hour, which is lovely. On the other hand, when we're prescribing antipsychotics and particularly antidepressants, we might need 3 weeks or even 3 months before we're sure about the value or otherwise of that medication. So when you're considering about how effective is a medication, you need to bring in the timing, the dosing, and the half-life of the medication before you can decide whether or not it has been a success or not. There are significant side effects that can be considered with most psychotropics, and the more you add in, the more you risk and the less knowledge there is about how those medications work together. Working as a pediatrician, I've seen quite young children come in on up to 4 different psychotropic medications, and I find that just absolutely nightmarish as considering what side effects, what are the interactions between these medications. If I'm going to prescribe more than 2 psychotropics, and that usually means a sleep plus something else, then I'm going to probably be discussing it with a child psychiatrist before I go ahead, or my colleagues, so that we have a group decision. We might also describe it with a team we're working with. So if we're working with Child Development Service or with Child and Adolescent Mental Health Services, then we might throw it in front of that team as well as to whether we've maximized single-use medications before we've gone to polypharmacy. So in the area of polypharmacy then, I would recommend that general practitioners be very reluctant to engage in this without discussion with pediatricians, child psychiatrists, or teams that are working with families. Polypharmacy is much more likely where families are disrupted, where there's social disruption, and where it might be more relevant to look at the social supports going into that family and what interventions they might be able to provide And of course, also within that, someone who can monitor the way those medications are being used. So we need really good planning if we're going to be thinking of that area. So just in review, use of childhood psychotropics is under research. People often prescribe off-label. We need clear and monitored targets. I just mentioned the most likely ones but that there's a limited evidence base. Symptomatic success reduces. We've got the increase in things over time. All have significant side effects. We must maximize any medication before changing or adding another, and drug interactions are common. Polypharmacy is an increasing problem, and we're seeing it in our outpatients, leaving us really quite uncertain about where we're going. Compliance is a problem, especially in disrupted families. And you must recognize the effect of labeling, particularly in schools, when you require a child to be dosed at school. So as a pediatrician, I always seek multidisciplinary inputs before I would go further, and certainly recommend that you discuss it with colleagues or child psychiatrists or pediatricians before going ahead. Now, in terms of the areas where we use the medication, the most common area is to support sleep. And quite often sleep in the families that we see is a problem, but it's often not a problem so much because of a neurodevelopmental disorder, but because of stress, family disruption, lack of routine, and so on. So that before you go to any sleep medication, you should be looking at what we call sleep hygiene. Sleep hygiene includes removal of things that tend to block sleep. So I'm sure you're all aware from your own personal experience that if you sit up watching television at night, you may well miss that pulse of melatonin that helps you go to sleep, because once you're past that, it's not going to come back. You only get one chance a night with it. And we see many children who are allowed up at night on electronic media, suppressing their production of melatonin. So we'll be wanting families to ensure that if there was going to be electronic media, it perhaps would be better before tea, and that after tea there are both regular routines, including things like book reading, reduction in noise, use of music, reduction in light, and all those things that support melatonin production. There are quite a few people who know quite a bit about sleep hygiene, including a lot of therapists. Occupational therapists have got really good knowledge. A lot of psychologists have really good knowledge of sleep hygiene. So if you think that's a significant issue, then please go to those services before deciding to use a sleep medication. Of the sleep medications, most commonly used is melatonin. Most of us believe that melatonin is a relatively safe medication. There can be side effects like dizziness, headaches, abdominal pains. There's a tendency for people to get used to a particular dose and to use accelerating doses. So the way we use it would be always to start off with a minimal dose, try and build in childhood breaks. For example, the time we really want good sleep are the nights before school days. So if you're going to suggest an optimal use, it might be to provide it the nights before school and then have the weekends free of it. So Friday, Saturday night, free of it, to at least get a chance to reduce that effect of getting used to it, or tachyphylaxis as we call it. The timing of it at night, if you've got a child who's bouncing around like they're on the end of a live wire, it's pointless giving melatonin. You need to have a child who is slowing down. And so it's just not useful. So generally we'd say try and time it for between half an hour and 40 minutes before you expect sleep. And you'll be saying to parents, only give it when you're quite sure the child's already beginning to slow down. What we're trying to do is support the melatonin peak that the child is going to get to help initiate sleep. Now, that is a significant point, because whether you're using melatonin or the other commonly used medication, which is clonidine, these are only effective for around 3 to 4 hours. So you're really only using them to initiate sleep. They're not such successful choices if you're wishing to maintain sleep in a child who's going to sleep okay, but then re-waking later. That would be a different pattern of decision making. But for most children we deal with, it's getting off to sleep that's a significant problem. So melatonin would be a reasonable choice. The sad truth is that it's a lot cheaper offline than online. So it's a lot cheaper non-prescription. So if a parent goes to a site like iHerb, they can generally get 2 or 3 milligram tablets, many of which are sustained release, which means that they can't be broken down or crushed. Melatonin can be compounded by compounding pharmacists, but it makes it a very expensive medication and beyond the reach of many families that we deal with. So they can crush tablets, but they must recognize that then they will only be useful to go to sleep, not to maintain sleep.
In this idea of a slow release versus a is there a rapid, or is it just the fact that the capsule is covered?
Yes, that's correct. So clonidine is a rapidly short-acting medication,
right,
and it's only the capsule that means that it's slow release. The medication still acts with that rapid speed. What we're trying to do with slow release is replicate the body, which has a slow amount of melatonin being released throughout the night following that big peak. Clonidine has been quite widely used. There remain significant concerns about its side effect. It's an alpha-2 agonist, and it basically works by dropping your blood pressure and making you very tired. It slows the pulse down, and there are some who feel that we should not be using it. There are others, including the Royal Children's Hospital, who have it on their website with the recommended doses and the way to use it. So if parents are going to access it online, somewhere like iHerb or similar ones can provide for it, but you must warn parents that you're not sure about the bioavailability of drugs that people get from non-prescription drugs. However, having said that, many parents report that it's as successful as prescription medication in my non-trial experience. Okay, so clonidine is also short-acting. It has other uses, and if it's also used in the daytime for, say, ADHD, as is sometimes done, then you must be aware of its interactions as well, because it will interact with other psychotropic drugs and has interactions with other drugs that you must look up before you recommend the use of clonidine at night. So the next group of drugs that we're going to discuss will be those used for children with attention deficit. Roughly 50% of the children who receive medication in this area primarily receive it because of inattention. Because the significant problem with inattention is that children will not learn successfully in the classroom. So not learning successfully in the classroom because of inattention is one of the indications for use of a stimulant medication where non-medication treatments have first been utilized. Parents, however, are more likely to demand it for children who are hyperactive. And we have to differentiate normal hyperactive behaviors. For example, normal 4-year-olds could only be described as hyperactive. And so you would have to be very wary of prescribing children for children under 5 who may meet normal behavioral ranges for that age. If we're going to use attentional medications, you have to be aware of the side effects. There's a tendency for disinhibition when you first use it, so that children initially can show anger. They can actually become even more active for a temporary period. They can become quite weepy, though these 3 pieces of problem do tend to wear off after 2 to 3 weeks of continuous use. But it is an indication that you should start with a very small amount and slowly build up. And we'll come to that in a short while. The stimulant medications are all inhibitory of growth. So they do that through the suppression of appetite. And you can use your timing of medication or the way you use your stimulant medication to try and make sure at least there's 1 meal a day where there will not be appetite suppression. So you can possibly time the first one to be after breakfast, or time a medication to have run out before tea in order to at least get 1 meal a day where it's possible that a child will have a reasonable appetite. Having said that, nearly all children who go onto stimulant medications, once they've reached effective clinical doses, are probably going to lose weight. And I find it pretty well normal to see 1 or 2 kilogram weight loss that once you've reached that will then track upwards again. So a child will remain 1 or 2 kilograms below their previous weight centile. If they show continuing weight loss, that would be a significant problem, and the whole use of that medication would need to be reviewed. After 3 months of that weight loss, a child's height centile will then begin to flatten off a bit. Now, if stimulant medications are ceased in early adolescence, it's believed currently that the final height of that child will be the same as the genetic expectation, though achieved 1 to 2 years later. It is becoming more common to continue to use the stimulant medications into adult life, however, and we believe that those adults may well be 1 or perhaps 2 inches short of their expected final height. Whether that's a concern or not is another question, but the families certainly who are utilizing it would need to be aware of that problem. Perhaps the thing that most concerns parents about the use of medications is the influence on sleep. Most children who get medication later in the day or who are on longer acting medications will have an inhibition of sleep, so that we then need to think about sleep hygiene. We may need to strengthen our strategies within sleep hygiene to ensure that this won't then adversely influence the next day's function. Sometimes it's necessary to recommend the addition of one of the medications we've discussed, preferably melatonin. However, we'd prefer that you look at the timing and dosing of the medication to try and see if we can get around that problem of initiating sleep. I have to warn you that children who already are showing us obsessive behaviors, tics, Tourette syndrome, may all have these problems worsen. So, for example, in the area of the autistic spectrum disorder, you would need to be particularly careful in the way you initiate and accelerate the use of stimulant medications because of the exacerbation of obsessive behaviors or restricted ranges of thought. So just be aware of that when you're selecting to use it and reduce the amount that you might introduce. Tics are only occasionally a problem rather than regularly a problem. Mostly it's a problem of increasing tics that were already present, but there are some children where tics occur where they were not previously occurring, and then that raises the problem of how you would best manage that. One of the biggest areas of problem in prescribing stimulants are they're probably the most misused drug. They're commonly resold on the street, so that you would need to be aware of the way the family are using the medication you have prescribed. So if you're prescribing stimulant medication, to be particularly aware when repeat medications are being asked for, and particularly when your new scripts need to be initiated. Is that the expected time that those scripts should have been used?
I think also the thing that we often encounter in general practice is a new patient who comes in going, you know, I've been prescribed this by my pediatrician, but we haven't received a letter or handover or anything like that. So that is a challenge. I sometimes will phone, PBS just to see when the last script was.
I would strongly recommend either phoning PBS or phoning the previous prescribing doctor.
Yeah.
Or the hospital. It may be necessary to. So we would commonly ring hospitals where a child's come from to find out exactly what has been happening. I must say it's a lot better now that this is all electronic. Electronic prescriptions within hospitals. It's easier to chase down. I would not readily accept someone just demanding it on their say-so before you've got some collaborative evidence. It's not unreasonable to ask families to chase that evidence and provide it for you.
And it becomes really tricky when the child transitions from a children's service to an adult service for GPs, because then that PBS requirement is you need a specialist to support that.
Correct. The other difficulty is where children are in care.
Yes.
And they're undergoing changes of care. We would expect that child safety should be providing us with accurate information about that. And if they have not, then it's quite reasonable to demand it.
Yes, we are working on that at the moment, and I think it is happening. So that's great.
So we're moving on from that class of drugs. We're going to come to it more specifically in a few moments. We're just going to briefly discuss the use of antipsychotics. Predominantly now, these are prescribed off-label. They're only on label for autism and for disruptive behaviors in children with proven learning deficits. Otherwise, their use is off-label, no matter who's prescribing. There are significant side effects, including weight gain, acute dystonias, akathisia, which is the restless leg syndrome, sometimes tardive dyskinesia, anticholinergic syndromes. Even the neuroleptic malignant syndrome is possible, particularly when you've got interactions with things like antidepressants. So you have to be really aware of that. They're occurring because these are dopamine blockers. And if you completely block dopamine, then you're going to get an acute neuroleptic malignant syndrome. Withdrawal emergent syndromes are common with antipsychotics. So I'm just going to put those warnings in before we come to discuss them specifically. Antidepressants ideally should be short-term only. They can be used longer term as anxiolytics where they have a better prescribing base and where there is PBS support for prescribing for children with obsessive compulsive disorders and for severe depression. Quite a hard thing to define within childhood. You'll be aware that children have an increased risk of psychological activation when they're first put on antidepressants, particularly important to start at quite low dosage, perhaps even a quarter, and increase slowly. And particularly a problem if that is an adolescent who has previously given us any suicidal ideation. We would need things like suicide watches for at least the first two to 4 weeks, regular contact with the family, and so on. So it is a significant problem, even with the most accepted medication which we'll come to, which is fluoxetine within this area. Acute serotonin syndrome is possible within this area, particularly when we're dealing with drug interactions. We expect changes in heart rate, blood pressure, and we would expect an ECG to have been done before you begin children on antidepressants or antipsychotics. So if we go on now to think perhaps more specifically about the usages of these things. So in attention deficit, our assessments would be wanting to show us that the symptoms not improved by non-medication approaches significantly interfering with either learning or with class management. There are contraindications where you believe that the family may not be able to manage these medications, where you might have to think of a different way of dealing with them. There are the comorbidities that a child may already have with aggression and depression. For example, if you've got a child who's already aggressive and you begin antistimulants, then there may be an exacerbation of those symptoms when you first begin them. Again, begin with very low dosage, perhaps a quarter of the expectation. Just use single doses before you move on. If you do correctly choose a stimulant medication and you have the correct diagnosis, then there is a pleasing 70% response rate for children. This improves to a 90% when you tailor it, when you get the ideal dose and the ideal time. For example, the common way we begin it is to give a dose 20 minutes before school starts, and just do that. Then if the teacher reports, and sometimes you might choose to not tell the teacher so that we can get the parent interrogating the teacher after a week just to see has there been any change in the child's behavior as an independent. However, it's probably nicer to let the teacher know, but it reduces the value of doing it. For example, when we begin it, I'd be offering the teachers a SCAMP that I've mentioned before, a monitoring tool, or perhaps they could use the SNAP4 tool to look at weekly assessments to find out just, is my medication being effective? So begin it before school. Consider introducing a second dosage because it will run out at around midday, and both school and family need to be aware of that. And it may appear that the child then, as they come off it, is worse behaved than before. But all that's really happening is the child going back to their pre-morbid state. However, it may show that we need a greater cover than that to cover the rest of the day. I would initially keep adjusting, firstly the dose before school, and secondly the 11:30 to 12 o'clock dose, to find the optimal dosage that covers the school day with both improvement in learning, if that is the target, or that child is no longer disruptive within the classroom, if that is the target. I would then strongly recommend introducing a long-acting beta stimulant. So in terms of the short-acting, that would be use of methylphenidate, would be aiming preferably with a maximum of 1 milligram per kilogram per day, but some people do take that further, but I'd be wanting support before I went to a dose greater than that. Dexamphetamine is a 5 milligram tablet. Most pediatricians I know begin on methylphenidate because we're more comfortable with it. Its side effects seem less. But then it's worthwhile going to dexamphetamine if you believe that the methylphenidate is being used properly, but is not successful. And about 20 or 30% children will then respond to dexamphetamine who have failed on methylphenidate.
So would you do a shorter review with them, like 2 weeks? Or?
Absolutely.
Okay.
And I'd be wanting them, at the very least, to contact my office about what's happening.
Yeah.
We sometimes ask GPs to do that. We sometimes ask support services, if they're present, to do that. So if NGOs are visiting, they can be very helpful in that regard. And we certainly want the school informed. And there are a number of teachers who are willing to call us, but many find it easier just to email us with their SCAMP or their SNAP4 if that's what they've used. When you're going to long-acting, you can choose either to use Concerta or Ritalin LA, and there are variable doses. If, for example, you've discovered that with methylphenidate, the ideal is, let's say, 1 tablet before school and half a tablet in the middle of the day, that is 15 milligrams, you'll probably need to go to 18 milligrams of Concerta or 20 milligrams of Ritalin LA. You'll need a little more because it doesn't come in with the same hit. Although Ritalin LA reduces a little faster initially and Concerta a little slower. There are variable doses that you can then work through if that's required. If you've been using dexamphetamine and you wish to go to a longer acting, then you might look at lisdexamphetamine in tuna. Brain's gone dead for a moment. But lisdexamphetamine, which action runs between around 2 and 12 hours, so you need to give it earlier in the day or even at night, and we're looking at doses between 30 and 70 milligrams a day, so it will be a different sort of size dosing than you've been using with simple dexamphetamine. In general, we'd expect that the decision to use lisdexamphetamine would be made by a pediatrician or a child psychiatrist, but there can be benefits over it compared to the longer-acting methyl, other longer-acting stimulants because of its particularly long actions. In terms of the benefits that we're seeking from the stimulants, we're wanting to know that the child's better organized, that they're better able to think through things before they respond. For example, not just blurting out things in the classroom. They're better able to stay in their seat. They're better able to share activities with other children. But on the other hand, that they don't have the irritability persisting. They don't have continued weight loss. Their sleep is reasonable. They're not showing us tic activity. And that we're not seeing obsessive or anxious behaviors that I mentioned earlier. Some families find the rebound with short-acting particularly disturbing, and that's one reason to go to longer-acting. We generally find that with long-acting, the rebound is not so noticeable. Trials for particularly the long-acting medications or even short-acting and the adjustments you make should be for no less than 3 months unless there are untoward side effects. So always starting at a low dose to find the least effective, increments no shorter than 2 weeks, optimizing before making changes, monitoring efficacy and side effects, plans about whether you're going to use them on non-school days or not. For example, if you're only using it for learning, you can choose not to use these medications on non-school days. We need written materials for parents and for teachers, looking at both why we're using it and for the assessments that we need them to make. They may fail. We may need to go to non-stimulant medications. These again would be decisions probably made by a pediatrician or child psychiatrist to use atomoxetine or to use clonidine, or perhaps the longer-acting clonidine version, which is guanfacine, which is becoming more popularly used at the moment. In general, we might choose to use guanfacine because it's long-acting clonidine, and therefore it's a little bit sedating and tends to damp down aggression. And it might be valuable where a child has failed on their stimulant medication because of aggression. In general, guanfacine might be used at night because it shows the typical clonidine effect, of being sedating, so it may help children go to sleep. And then it will continue to act through the next day because of its longer acting activity for attentional deficit. So that is a possibility to use short-acting clonidine. The dosing it can be difficult. You wouldn't be wanting to use more than 100 micrograms a couple of times a day, or dividing it further down, perhaps slightly higher doses in adolescents. So now we're going to go on to antipsychotics. Generally, the primary reason for prescribing antipsychotics is for disruptive and aggressive behaviors. Very commonly, these are occurring not because the child has a neurodevelopmental disorder, but because of unstable homes or background. And we'd certainly be wanting a significant intervention or supports for those backgrounds before considering antipsychotics. We might also look at whether the aggression is the result of, say, an attentional deficit, where prescribing a stimulant might ease the aggression because the child's less frustrated. Nevertheless, we do come to the decision sometimes that a child is so disruptive and aggressive that neither the school nor the family can manage them, and that we might need to use them to damp down that activity until we can put other strategies in place. They are PBS permitted on authority for use in children with autism and disruptive behaviors, and for children who have intellectual impairment and disruptive behaviors. The most common prescription, however, is the use off-label. And again, we'd be wanting to start with quite a low dose. It comes as 0.5 milligram, 1 milligram. And for children, we'd really not be wanting to use more than 1 or 2 milligrams a day at the most. We do see children on greater doses than that, but you're beginning to see significant side effects once you start to increase those doses. Risperidone is a sedating medication. It may be best prescribed at night to support anything else you may be on, because then it will help the child sleep. And because of its long action, it will continue to help suppress aggressive behaviors the following day. So in discussing it with parents, you'll be saying what we're primarily doing is trying to slow down the speed with which your child becomes angry. So we're wanting to know that all the things that otherwise help reduce anger are also in place in terms of family stresses, excessive electronics, and so on. So the lowest effective dose will be 0.5 milligram. There are liquid preparations which are more expensive, and they are all off-label for the general reason that we prescribe them. The benefits are often not sustained, sadly, and quite common. And this is often because the background stresses and strain have not been resolved or dealt with adequately. Parents will come in saying, I need more, and I'd be strongly resisting this as the primary approach to take to deal with these aggressive behaviors. We need to be very careful with weight. There can be massive weight gain with risperidone. Olanzapine is occasionally prescribed. It has even more weight gain. If it is a successful medication in managing our problems of aggression and violence, then, and we're concerned about weight, then we might look at quetiapine or aripiprazole, but I would never do that without discussing with a child psychiatrist or with a team of other people involved in the same area. I think these decisions as to which one to use are difficult, and the most commonly used and best understood would continue to be risperidone. Beware in boys, particularly in adolescents, that risperidone increases prolactin. And amongst the other monitors that you need to put in place when prescribing antipsychotics, you would need to monitor prolactin levels in adolescent boys. They can be an issue for girls as well. They can interfere with cycle, so you need to be aware of that. Probably good to monitor for both. So you'll be monitoring, in other words, BMI, lipids, prolactin, hemoglobin A1C, because of the amount of weight put on. These children are at increased risk from type 2 diabetes, and initially at least liver function test. Generally, you can drop that later on. There is some suggestion that girls may be at increased risk from polycystic ovary, from being on these medications. So what I'm saying is please be aware of it. So for the most part then, risperidone will be used. If aggression is a particular problem with then quetiapine has more sedating properties than the others. But again, I personally would be very wary of prescribing it unless I had support through child psychiatry. Let's now talk about the antidepressants and anxiolytics. Through the PBS, these are really only on label for severe depression, for obsessive compulsive disorder, and there's some controversy about whether for selective mutism or not. So they may be appropriate to use. They can be used in adolescents with panic attacks, but the majority of prescriptions are for children who have depression, and it's interfering with their function at home and at school. Often it's prescribed as a comorbid thing. So we would be thinking, if we're going to use it, because we've already used psychology and other interventions, then we'd be hoping that perhaps we could just use it for a 3-month period at the most, and then come off it again, just to see whether we can now manage. Fluoxetine is the best evidence within childhood. However, it has been associated with an increase in suicidality, albeit not great in numbers. It's a real risk because of the initial activation. So I'd be recommending starting on quite low doses, maybe only 5 milligrams, and then going to 10, then going to 20 in adolescents, and proportionately less if you're using it earlier on than that. There is some use of sertraline, particularly in children with obsessive compulsive disorders. I would again be probably consulting with a child psychiatrist before utilizing sertraline. It's a sometimes tricky dose. It has more drug interactions than others, and it can certainly show initial activation. So I'd be really wary of it, but it does have a role in obsessive compulsive disorders. Fluoxetine does have a role in childhood in selective mutism, which is a very rare disorder. And it's particularly perhaps the medication of choice as an anxiolytic. So if a child has a severe anxiety disorder, then it is PBS supported. But for most children we see with anxiety, we really couldn't call them severe anxiety, but it may be appropriate to use it where that anxiety is interfering, particularly with the ability of a child to go to school or to manage within a school environment. So just be wary of it. It has a very slow onset of action, so you would need to be sure over 6 months whether it was effective or not. When you withdraw it, you are at risk of withdrawal syndrome, and so you would withdraw it very slowly, preferably over at least 2 months.
It does have a longer half-life than sertraline, which is, I
Yes.
think, a positive as well for children who might miss.
Indeed.
Yeah.
Indeed. So again, with parents, we need to be sure about compliance, either for that or the antipsychotics, being wary of homes that have significant disruption. So there are things that you may not think of, even with fluoxetine. For example, it will interfere with fentanyl, which is commonly used in emergency departments. And so we can see serotonin syndrome sometimes when it's combined with that. So we need to be sure that family and everyone is aware that this child is on such medication. Well, I'm going to stop now. We've talked about being very careful about this way we use and make the decision to use psychotropic medications. We talked about the general classes that we use: sleep, attentional deficits, antipsychotics, and antidepressants. We've spoken about each, about being sure that there's a need before we resort to them, that we have adequately used and maximized non-medication approaches. We then need good monitoring, and both for the positive effects and for the negative effects, before we can decide whether or not that's been a useful thing to do. We need to be very careful in the use of antipsychotics and antidepressants. And I'd certainly be hoping that people would be consulting with others before considering these medications. Thank you. And now please use the chat box for any questions that you might have.
Haven't seen anything come through as yet, Ian. I think what I heard and what I've seen in the clinic is especially that you know, with antipsychotics and puberty and things like that, I think as GPs we have a particular role to play in terms of monitoring, as you said, and I really love the list of blood tests that you've identified there, because that's something that I must say, I sometimes have seen polypharmacy, and and I really, don't know. It's confusing then. What do I monitor? Because the risperidone's increasing appetite, the Ritalin, is decreasing it. You've got, all these different interactions. So I think just having a basic approach, weight, height, and then the targets are very important as well. So I felt like that those were some of the key things that as general practice we need to be aware of.
Yes, and that just as a pediatrician, I have to say that we get confused when it comes to polypharmacy. And I fear in the long term that we may look back at some of the polypharmacy we've been involved with and wish perhaps we had done more to maximize non-medication approaches, to look at the way we can support families without having to resort to medication. But don't forget supporting schools as well. Schools need a lot of support with these difficult children in helping manage the children. And we might, for example, I will often suggest to school that the child misses out half a day, maybe have Wednesday afternoon off or all of Wednesday off. Because some children who are greatly stressed will learn better if they're on partial schooling rather than whole schooling.
And that you basically would write a letter.
I've discussed it with the school as well.
Ian, we don't have any questions and we have gone a little over time, but that's because of our technical skills. So we might end the meeting and thank everyone for their attendance.
I'd just like to thank everyone who's attended this series. I do hope you've enjoyed it. Please feel free to contact through the PHN with any significant questions about any of the webinars we've done so far. I would like to suggest that if you wish, that I'm willing to come out to individual practices and discuss some of these matters. If you wish, please contact through the PHN if you wish that to happen.
Thank you so much, Ian, and thank you for sharing your wisdom and knowledge with us. As you can see, I'm always taking notes. So it's been wonderful. We will also have a look at how we can get this the time, even if it's self-learning online, to be accredited for continuous professional development as well. So thank you everyone for joining us online. I am going to try and end this meeting, but if I fail, you might hear some background noise. So thank you for your time.